Hello. I'm Kat Livingston. So as was mentioned, I work for the Health Evidence Review Commission, which determines coverage for Medicaid in Oregon. And so about 3 or 4 years ago, we identified that we had an issue, which is that back pain for Medicaid patients in Oregon was not a funded diagnosis. And it's too complicated to explain what that means. But essentially what that meant is that patients with back pain could see their PCPs, they could get opioids, but they couldn't get any type of other treatment. Simultaneously, we had done a series of evidence reviews looking at non-pharmacologic therapies and knew that there were a number that had an evidence base. And also concurrently, we were in the midst of the opioid crisis and knew that we had a very high opioid prescription misuse in Oregon. So given all of those factors, we convened a public multidisciplinary task force and came up with a new policy, which I think Dr. Alexander is talking about what different people cover, but this is fairly revolutionary for Medicaid and even for some commercial payers. So we had a new back pain coverage paradigm. So newly covered for patients with back pain were all of the things that worked. Were cognitive behavioral therapy, spinal manipulation, acupuncture, physical therapy, occupational therapy, non-opioid medications. The other things that we know work were yoga, interdisciplinary rehab, supervised exercise, and massage. We knew that there were going to be some significant implementation barriers to these other therapies, so we added a caveat to our policy that said if available, knowing that across the state they wouldn't necessarily be. But the intent was to cover all of these newly for patients with back pain on Medicaid. Simultaneously, we wanted to cover less of the things that don't have evidence or have evidence of harm. So we created a guideline that limits acute, subacute, and chronic opioid prescribing for back pain. We stopped coverage of epidural steroid injections and other injections based on a lack of evidence of efficacy. We don't cover TENS, also due to a lack of evidence of efficacy. And for back surgeries, we decreased those and just formalized our criteria a little bit more to make sure that the patients who were receiving back surgeries were the ones most likely to benefit. So the other thing that we did, and I threw this in at the last moment because of what we discussed yesterday, but we do a risk stratification. So patients with back pain are risk stratified according to the START back tool. Patients who are low risk can get up to 4 visits of this expanded benefit package, and patients who are high risk can get up to 30 visits. So this was obviously wildly different than what they were able to access before this policy went into place. And again, what is not recommended is first-line opioid prescribing or long-term opioid use. So that is our policy, which was many years in the making and 2 minutes in summary, which is I thought that was reasonable. But this is currently being studied. There's a PCORI study and a NIDA study both looking at the impact of our policy. So look forward to that in the next few years. So in terms of the challenge, we were asked to talk about the challenges. So there are a lot of challenges to doing this kind of policy, and particularly from the Medicaid perspective. The first one is cost. And I know yesterday we heard some presentations that talked about maybe cost savings and things like that. That was not at all what our actuaries thought. This was a very expensive change in policy. And we went into this policy knowing it was going to cost a lot of money. And we were willing to do that. And so I think and I'm interested with Optum, who also, is imagining a lot of cost savings, and maybe our actuaries and your actuaries should get together. But we made this decision knowing it was going to cost a lot of money because we thought it was the right thing to do. There are a lot of issues with reimbursement. And so with yoga providers, we really want to be able to pay for a $15 yoga class. That seems like it's an evidence-based therapy. It's inexpensive. If patients want it, that's great. But for Medicaid to pay a yoga provider is almost an insurmountable barrier. Thankfully, we figured out how to surmount that, so that's good. And I'm running out of time, so I'll highlight the things. I'll skip to the next slide. So in terms of the evidence needs, I think we need a lot of evidence that focuses on critical outcomes. Pain scores at 2 weeks is not an acceptable outcome, I think, for this literature anymore. We really want to look at long-term function. We need evidence on how this affects opioid use. For payers especially, knowing how much this affects inappropriate utilization, such as emergency department visits, is critical, and also return to work. And if that's embedded in some of these research studies, that will be really appealing to Medicaid payers. This dose response issue is critical. If we are paying for 30 visits, but 15 visits is just as good, or 60 visits is way better, that's absolutely going to change payer policy. Right now, most of the payers cover 30 visits because most of the payers cover 30 visits. It's not evidence-based, and that's a little bit crazy. So I would suggest dose response information. And finally, really studying the impact of payer policies. You know, coverage has been alluded to a lot of times in the last day and a half, but understanding how much once we make these policies, how much that actually changes outcomes, you know, and how much that increases access, and what are all the barriers. I think this is critical to study. Thank you.